All right, so good morning, good afternoon, and good evening, everyone. I am very pleased to welcome you to the Dean's Lecture Series that the iSchool at the University of Maryland has been hosting this academic year. My name is Megha Subramaniam, and I am a professor at the iSchool, and I currently serve as the Associate Dean for Faculty. I have the absolute honor of introducing the speaker for today, Dr. Sridhar Venkatapuram. Sridhar is an academic practitioner in global and public health ethics and justice. He is an associate professor in global health and philosophy at King's College London and the deputy director of King's Global Health Institute. Sridhar has been at the forefront of public and also global health ethics for over 25 years, starting in the early 1990s as the first researcher at Human Rights Watch to focus directly on health-related human rights violations, HIV and AIDS in India in particular. And Sridhar is known for helping establish the area of health justice philosophy, for engaging with and advising public health practitioners, and for amplifying ethical reasoning in public or global health education research and practice. Sridhar has been awarded numerous awards, research fellowships, and elected to prestigious professional organizations, commissions, and panels. He has worked with diverse health equity organizations such as Population Council, Open Society Foundations, Wellcome Trust, and the World Health Organization. So before I hand this over to this very accomplished person that we are so excited to have with us today, I'd like to encourage everyone to post questions that you have for Sridhar as he is speaking in the chat. So if you post in the chat, there's an option to select everyone or just the host or the panelists. So I will monitor the chat and we'll keep track of that. Sridhar will answer all the questions at the end, and we'll also have more opportunity to engage with Sridhar at the end of this, towards the end of the session today. So with that, please join me in welcoming Dr. Sridhar Venkatapuram. Sridhar, the session is all yours.
Thank you very much, Megha. And so let me begin by first thanking Megha and Sarah and all the others that have helped bring me here, particularly to the Dean and also to the individuals and committee that have sort of selected the speakers. And so this has been planned for a long time, and I want to sort of start by acknowledging my gratitude for being sort of given this opportunity. And then I also want to say just a couple of housekeeping stuff, which is that my computer only sort of acts up on important occasions. Every other time it's fine. If for some reason this doesn't work today, just please hold on and I will join back. And I'm sure you're used to these kinds of things by now, but I just wanted to say ahead of time my apologies, and I will join you as soon as possible. So let me begin by stating that, my talk is about information, sound knowledge, and health justice. And I think that one of the reasons that I've been invited to speak today and this year has been that the idea of health justice is on the forefront of many people's minds. It's on sort of increasingly a concern of policy. But more specifically, the concept of health justice is something that people are trying to get their head around and trying to figure out what it means. What I want to do today is sort of give you my perspective on it. So I have been working on this idea of health justice for about 2 decades. And really the way that I use the term health justice is that it is an area in philosophy, particularly political philosophy, where we work on theories of justice. So the idea of what is social justice and what is global justice and what does a good society look like, etc. And my work has been to incorporate our concern about health into those kinds of theories and theorizing about social equity and social justice. And so over the last few years, all of us have experienced a great shock to our lives, but also understood very clearly about having a health threat in our daily lives and what that means in terms of how we protect ourselves, our families, and also perhaps if you have a place as a community leader, but also in a university and as a nation. And so the idea is sort of how does health justice apply at all these different levels, and what does it particularly mean to individuals such as you who are academics, faculty, students, researchers who are working in information at the iSchool in a variety of different ways about sound knowledge, and how do you sort of maintain it, produce it, guard it, protect it, disseminate it, etc. And I can't think of a topic that's more important to me than this concept of sound knowledge and health justice. I find that they are so incredibly interlinked. So it's been a great privilege and a sort of valued opportunity for me to be able to speak to you about how I think about the relationship between knowledge, good knowledge, and health justice. So I'm going to start very sort of from a personal point, a personal story, and then I'll go into two examples in which I think sound knowledge, information, and health justice are linked. The first sort of departure point is that I want to tell you that, first of all, I am based in London, in the United Kingdom, or England, as some would say it as well. But I'm an American, and I grew up in America, and I grew up in the Midwest, in Minnesota, and I studied on the East Coast. And when I was doing my PhD at this small university called Harvard, there was, for me, a real sort of problem that I found is that the topic that I wanted to study, which is sort of basically the human rights approach to health or a human right to health, I was sort of finding resistance in a variety of different kinds of ways. And I want to talk to you about different kinds of lack of information or lack of knowledge, even at such a prestigious and very resourceful university. So, for example, the concept of human rights is not very well appreciated or acknowledged or taught in American schools and universities. And even at a place like Harvard, there are very few courses on human rights, and the only course that was available during my year was in the law school, and it was a human rights law course. That spoke to this idea of, well, is this the only way to look at it? And what do I do if I don't want to be a lawyer and I want to learn more about the philosophy and other kinds of aspects of human rights as well? And the second part, which I found really troubling as well, is that many of you who are interested in inequality will know that many American universities during the 1950s and 60s shut down their sociology departments and other departments which studied inequality. And so they thought that essentially that this idea of focusing on inequality and social inequality and this thing called society was very sympathetic to a communist or a socialist mindset, and they found it to be too un-American. And so there's been a lot of history written about this shutting down of sociology departments, and therefore there was a great stifling of the study of inequality. And so you will see that very many of the sociology departments that we know now in the United States are fairly new. But in comparison, sociology in other countries is very sort of different, and it sort of has a very different flavor to it and a lot of different kinds of history. But if I was interested in health inequalities, that concept itself, how do you learn about it, it, who teaches it, how can we think about it, there were very few places, even within a university, where I could go and sort of think about it. But you will find that in comparison, economic inequality and study in economics departments is very strong and very flourishing, but that's not where I wanted to study. I didn't want to study healthcare finance. I didn't want to study economics of health. I wanted to study health inequalities. The third kind of area which I found very limiting was that even in the public health schools, when you learn about different kinds of diseases and you learn about how to do epidemiology and biostatistics, one of the peculiar things that the United States system, universities do, is that if you were studying about health inequalities, for example, and you were sort of looking at cancer rates or heart attack rates in a population, so they'll say, well, let's stratify by race, and they will stratify by whites and blacks. And what I found is very peculiar about what not only the fact that you would stratify a population by race and sort of say, well, what are the white people suffering from and what are their rates, and what are the black people suffering from and what are their rates. And so you sort of think about these two different groups as having different kinds of rates of health, and them being relative to their particular racial group at that time. What also troubled me about that is that America is not just made up of white and black people, it's made up of many different kinds of people, and my included as a sort of a new American. I was like, doesn't make sense. I don't even belong in this picture, and so nor do many of the other kinds of people in America. And so that was also a very kind of limiting sort of area, and I was sort of very frustrated by all these different ways in which, if I wanted to study health inequalities and think about justice, think about rights, I was sort of found it very hard to sort of do so, even at such a big university. And this is the reason that I ended up in the United Kingdom studying here, is because here there are different kinds of understandings, different histories of both human rights law, but also generally this notion of rights. There's also a different understanding of health inequality, which actually looks at it from more of a social inequality, socioeconomic inequality, and not just race, but it looks at other kinds of developments as well. And also, I think, it also thinks about justice and social justice in a very different way. So I wanted to start out with that because I think that, this notion about information and sound knowledge and health as being, very much intertwined in a significant kind of way is something that I feel very personally, particularly because the reason I went to graduate school to do a PhD in public health and human rights and justice is because I had spent about 5 to 10 years previous to that working on HIV/AIDS in the United States and India. And so it was something that I knew and experienced very personally about the importance of knowledge and information as being life-saving. And so to find that even at a big institution, there were sort of very confined notions of knowledge and information, and this was actually going to limit my understanding and work. And so this is why I came to the UK. So I want to bring that personal story to more of the intellectual sort of arguments for this talk, and how I would hope that I convert all of you to understand how important sort of this idea of information, knowledge, particularly the free exchange of sound knowledge, is central to our lived sort of experience on a daily basis, but also our life expectancy. So I think that, this kind of talk and presentation before 2020 would have seemed very abstract and very theoretical, but I think every one of us now will be able to appreciate this one fundamental thing, is that our ability to be healthy, our ability to be able to live a long life, our ability to prevent a sort of a fatal disease or infection depends a lot on our ability to control our own body and behavior, and that this control over our body and behavior has to happen not just at one day, 1 hour, but it has to happen over a period of time, over many months, and perhaps a lifetime. And this is something that women's health activists have been arguing for decades now, is that women's health is not just about pills and injections, but it's about transforming their ability to have control over their body and behavior. And this is also something that during the AIDS epidemic, a lot of gay men were talking about, is this idea of how do we enable individuals to have control over their body and behavior in order to be able to prevent a fatal infection. And this doesn't just happen for 1 hour or 1 day, but it needs to happen over a long period of time. So if you have this notion that health is not just about a pill or injection or healthcare, but it's about having control over your body and behavior, how do we think about this in terms of helping individuals, helping communities, and helping countries actually be healthy and protect themselves? So I want to start with one particular example. Prior to the pandemic, one of the examples that I always use is this understanding that famines do not happen in democracies. And this has been studied by sort of a teacher and mentor of mine named Amartya Sen and another economist called Jean Drèze, where they studied all these modern famines in the 20th century. And what they found is that there have been a number of famines that were quite brutal, particularly in China and Ethiopia. But what they found is that there were no famines, no modern famines in democracies. And the argument is that there's two reasons why they don't happen in democracies. One is the idea of access to information and a free press, and that wherever there is a free press, there is sufficient knowledge and awareness about that there's something bad happening, and that journalists are able to report that event in the newspaper and for publicity's sake, for getting social action to happen. So one is that a free press is essential in times of social crisis such as famines in order to be able to share the information about that. The second is that there is also an importance of accountability and political accountability. And in a democratic country, what happens is that if politicians do not respond to this free access to and free provision of information about a social crisis happening, then they get voted out of the office. So these two things have been sort of seen as to be really important for the prevention of famines. And but the irony of this is that persistent malnutrition persists in democracies as well as in other countries as well, despite having accountability, despite having free press. And so that is one of the reasons. The question is why is persistent malnutrition allowed to persist or allowed to happen while famines do not? And the second question is, why do epidemics happen in democracies if famines don't happen in democracies? And that's been something that I've not really considered closely, but it's something that's always been driving on the back of my mind, is that why did epidemics happen? Why does the HIV/AIDS epidemic, or a pandemic as we can now call it, happen in democracies while opposed to a kind of health crisis like a famine doesn't? And I want to sort of say that the two examples of why that happens and what are the different ways that we're coming to understand why this is happening is that, one, you may have heard for over the last year, 2 years, this concept of epistemic justice. And this is something that we in global health have really sort of fixed on because of a variety of different reasons. In global health, over the past 2 years, what we have brought to the surface, and many people have brought to the surface, is that most of global health research is done in rich countries, and it's done on issues that are identified as important by rich countries. The researchers tend to be citizens or members of the dominant population in the rich countries, usually white people, and then also it's usually men. And what this has meant is that this has profoundly affected the kind of knowledge that's produced and the relevance of the knowledge that's produced and how it's impacted the actual global health agenda and architecture. And so there's this argument that the knowledge producers are sort of based in one place only, and certain people are only able to produce knowledge, while people who are in many low and middle income countries who have full awareness of the issues are able to do research, are able to produce new knowledge, etc., are essentially being shut out of this kind of process. So that is something that global health as a huge enterprise has been trying to figure out how to deal with. And so the two major journals, the Lancet and the BMJ Global Health, have both made a positive effort to have a policy and also different ways in which individuals from low and middle income countries can start to contribute to knowledge about health issues affecting their own people, but also transforming the global health agenda. Why I am bringing that up is that what we have seen is that the reason why epidemics and a pandemic is able to persist despite all of what we know about what to do and what it's caused and how to protect ourselves and what commodities that are necessary to use it, is that we have essentially this question about who is producing the knowledge in terms of thinking back over this pandemic about who is producing the knowledge about the causation, who's producing the knowledge about the distribution in a population, who's producing the knowledge about how to care for people and what works and what doesn't, etc. And I think that this is very different from a situation in a famine, for example, where people don't really argue about what caused the famine. They're more concerned with there's a severe crisis happening and the government should do something about it. But here in an epidemic situation where it's from a virus or a pandemic situation, we have many more sort of questions that are at play and many more different kinds of struggles about who actually has access to that knowledge and production mechanisms and pathways. And even it still continues today. So I think that is the difference between why pandemics happen, why epidemics happen in democracies, while we don't see famines happening in democracies. And I think there's much more to be said about this. But in terms of just trying to establish this idea of knowledge production is actually not as easy as we think it is, and that it's actually confined in different ways, and that this actually has a significant impact on our health and also health inequalities in a population and also in the world. And so I'd like to give you two examples from my work about health justice that I think is really quite central, and it's two ideas that I think are unfortunately for a long time have been confused in the United States, but it's something that increasingly, just like this invitation for me to come and present to you, is that it's changing. And I want to talk to you about two ideas that I work on, and I want you to think about whether you think I'm correct or whether I'm wrong or whether I'm sort of not as clear as I could be, because I welcome that kind of commentary and questions. The first concept is this idea that health is not just about health care, but about the ability to be healthy or a capability. This is an argument that I've made, I think now it's been about 10, 15 years that I've been working on that kind of idea, and it's based on a sort of whole school of idea around social justice and what the idea of a good society should be. But what I mean by health is not just about health care, and it's about the capability to be healthy, is that I want you to think about the public discussion and debates about health in the United States. More often than not, it's focused very much on access to health care. And I think that this is both a really important thing, is that the fact that tens of millions of people don't have access to health care when they need it is a great travesty and an indication of injustice that we have to address. But at the same time, what we need to also focus on is that it's not just healthcare that's important to health, but it's actually, like I said, is how people are able to have control over their body and behavior. But more generally, this idea of, in order to be healthy, you need to be able to have a variety of different kinds of socially supportive conditions in order to be healthy over the life course. And so it's a very easy example to provide you, and many of you hopefully will resonate with this sort of illustration, which is that in, at least in the UK and in London, and I don't know how different it was in the United States in different parts, is that there were various kinds of stay-at-home orders or social distancing or lockdowns, as they're called. And the idea was that, in order to protect ourselves from passing on the infections to each other, what we need to do is stay at home and work at home in order to prevent infection and in order to also pass on the infection to others. But it was, unlike just sort of telling you to stay at home. What happened was that there was enormous amount of support that was provided by the government and other people. So for example, in the UK and in London, and in my case, the water, the electricity, the trash, the postman, were all sort of going to work in order to enable me to be able to live safely inside the home. But beyond those, there were individuals that were working in the grocery stores. They were making sure that there was food always in the stores, etc. So these are all different ways in which the environment was helping me protect myself and my family and others. And then beyond that, the government also provided people with different kinds of grants so that they would not suffer for not being able to go to work when they work on an hourly basis. So there was money given directly to people to ensure that they would always have food on the table. And then beyond that, the government also subsidized entire industries to ensure that the companies keep running so that they can provide work and income to individuals. So what I'm trying to explain here is this idea that in this sort of acute crisis situation, for an individual to be able to protect themselves from a potentially fatal infection, it's not just about what I can do on or within my body. It's also this idea of a supportive environment that enables me to be able to protect myself for a period of time. And then the development of a vaccine is one healthcare commodity that's incredibly important, that sort of further enables me to continue to be healthy. And I want you to think about that kind of story, not just in terms of this pandemic and this virus, but about health in general, which is that a lot of people, in order to be healthy, it's not just about what they do on their body or within their body. It's also about the kind of environment that they live in that supports their ability to be healthy. And other people don't have that kind of support. And why I am sort of focusing on this is that I would like for you to think about this idea of our conversation in the United States about health overwhelmingly is focused on access to healthcare and not enough on this idea of people's capability to be healthy over a lifetime and what that looks like and what that needs. And going back, I think this is a really important question, not just about sort of a concept or science, which there is much to sort of argue for it, but for your purposes, and the reason I'm talking to you is to think about it in terms of the knowledge and who's producing the knowledge about this and who is allowed to talk about this and who isn't, what sort of framing is done of issues by journalists, by politicians, by institutions, and also academic researchers that essentially keep the focus on healthcare rather than on health and health capabilities. This is something that an academic sort of can come up with a concept, but in terms of whether it sort of passes on and whether it's taken up really depends on these other kinds of really important movements in society that we need to address, I think, very closely and directly in order to be able to make improvements around health justice in the United States. The second example that I want to talk to you about is the argument that health inequalities require addressing what we call social determinants of health. And so what this means is that increasingly, many of you will likely have heard this concept of social determinants of health, what that is meant to signify and what is that alluding to is this idea that our health in a positive sense, but also the disease and morbidity and premature mortality are caused by factors outside of us. So it's not just genetic factors or not just about what we do as individuals in terms of what we eat and drink and exercise, but it's also a huge number of other things that happen throughout our life course surrounding us from the local to the global. So let me give you an example, is that the amount of stimulation that an infant gets between 0 to 2, all infants most often start out as sort of at the same kind of level of curiosity and movement and activity, but the amount of stimulation that they get over the first 2 years dramatically impacts their development, their neurodevelopment, their physical development, etc. And the question is that different children get different amounts of stimulation based on their social conditions. So in terms of what kind of family they live in, what kind of neighborhood they live in, what kind of social class their family belongs to, etc. So that sort of external conditions profoundly impact not only the individual but the inequalities across social groups, and that's something that very few people they know about. But the question is whether we can sort of start to or want to address something like that. But then it goes much bigger. So it's not only about sort of stimulation at the sort of infant level, but we also know that health is profoundly impacted by your working conditions and your work environment. A lot of people think that social determinants of health just means material poverty. So, oh yeah, of course, if you're too poor to eat, well, and you're too poor to have good housing, etc., this is going to somehow affect your biology and behavior. But the social determinants of health knowledge and the science around it is much more than just material poverty. So, for example, your working conditions, what they're talking about is how hierarchical and unequal your working environment is will actually distribute illness in that office population according to that hierarchy. So there's a very famous study called the Whitehall Study in the UK that showed that among British civil servants, as you go in the hierarchy from bottom to top in the civil service, people's life expectancy and other kinds of diseases matched the hierarchy. And what we find is that this is not just true inside the office, but it's actually true across society, which is that the higher you are in the social hierarchy, the longer and healthier you're going to be in your life expectancy and life course. And that kind of information is profoundly important for people to know about so that they move away from this concept of my health is because of my genetic bad luck or it's about what I do as an individual level. And so what we need to do is to think much more about how health inequalities in our society is actually distributed not just by individual behavior, but by a variety of social and external conditions that distribute disease in individuals and across social groups. And the reason why I work and why I talk about this in terms of health justice is because the fundamental argument here is that every human being and every US citizen and every person has a moral right to live a long and healthy life. And when we constrain individuals from living a long and healthy life because of the social conditions that surround them out of no choice of their own, but because they are born in a certain family, they're born in a certain neighborhood, they're born in a certain state, etc., or they're born of a certain race and therefore they're treated poorly as a result. These are all random and unjustifiable constraints on their ability to live a long and a healthy life. And so I think that this is the kind of reasoning that I've been trying to pursue which is this argument that it's not just about efficiency in allocating healthcare, and it's not just about sort of ensuring that people change their behaviors, and we address that, but to actually look much more at this argument that in order for us to ensure that individuals are healthy, we need to help them reorient themselves to around their abilities to be healthy. But second, the important thing about health inequalities is that we need to stop thinking about it just in terms of health care, but actually start thinking about the social conditions that are actually causing and distributing disease and premature mortality in individuals and social groups. And it's a question of social justice, because these are socially created harms in individual lives that we need to address. And now why I want to go back to that sort of initial point is that these two things fundamentally depend on the acquisition of knowledge and the sharing of knowledge and the use of this kind of knowledge. And there is very much, as I said, very much a constraint on who is able to produce this knowledge, who's able to share it, who's able to disseminate it. And I think that that's probably one of the most important aspects of health justice that most people don't think about, is that while we know what the problem is and what to do about it, the fact is that so much of this is constrained by limits on knowledge and how knowledge is created and used, that we have to really sort of establish the importance of the link between knowledge, production, creation, dissemination, and health equity and health justice. And that's why I was so excited to get this invitation, is because people like you who think about this and who work on this have the kind of primary experience and knowledge to address this problem, this link that we've sort of neglected for so long, is that it's not just about healthcare, it's not just about sort of knowing the science, is that there's a fundamental question here about knowledge dissemination and acquisition and health justice that has been unrecognized, and we need to spend more time sort of understanding it. I guess the last final point is that, during this pandemic, one of the things is that we've been comparing countries. If you're in one country, you're constantly looking at other countries to see how other people are doing. And one of the things that's happened is that people are very aware of the fact that some countries are doing much better than others, and that in itself has provoked a great amount of public discussion. And I think that this is a really important thing for the future of health equity and justice in the United States and elsewhere, is this ability to be open to comparisons across countries and to really re-examine some of the things that we take for granted, and to say, well, why is it that our people, more of us are dying than they are, and they're just human beings like us, so what is the difference? And I think that's the beginning of some sort of transformation, and I hope that that is really what this pandemic can really do, is in terms of the knowledge and the awareness of comparisons across national borders is, I think, going to be one of the most important things in the way that we improve health within our societies as well. So with that, I want to thank you again. I hope that that was sort of somewhat clear in what I was sort of trying to get to sort of share with you, is that, one, I think that there is a really important relationship between information, knowledge, and health. And I've sort of talked to you about how women's health advocates have talked about it. I've talked to you about how HIV/AIDS was so important about producing sort of knowledge that is relevant and useful to people. And then sort of talking to you much more about how in global health and health knowledge in particular, we've identified this problem about who is producing it, who can distribute it, who gets credit for it, what issues are being discussed, etc., that we sort of are titling this sort of problem of epistemic injustice. And I've talked to you about two concepts that I think are really important for health justice. One is this idea of health capability, not just health care. And the second thing is that health inequalities require us to look at much more on the social, structural factors that are causing and distributing health and poor health across people, and that we need to address the structural drivers of those health inequalities. And both of these concepts are not fully engaged with in the US. And I think this is why it's really important to start thinking about knowledge in relation to health, equity, and justice. And I hope that some of you will find this interesting enough to take this up. So with that, thank you very much, and I look forward to your comments and questions.
Thank you, Sridhar. That was fantastic. Thank you so much for giving us so many things to think about. Audience who are in attendance today, please feel free to post your questions in the chat. I will read them as you post them. And if you prefer to raise your hand and ask questions yourself, please do that. We have the fantastic Sarah Grant, who is doing some behind the scene work, and she will be unmuting you when you raise your hand. As our audience just get trying to post their questions on the chat and just getting warmed up, Sridhar, I like to start by asking you a question. Again, very fantastic presentation, and I feel like you gave me so many things to think about. So one of the questions that I would like to ask you is that what is the role that you see technology plays in some of the points that you have raised in terms of achieving and also maybe curbing health justice, right? So you talked about the role of free press in terms of the famine and also pandemic. But we all know the technology, especially during the pandemic, played a great role in providing information and also providing misinformation and disinformation. So can you speak a little bit about that, Sridhar?
So I think that since the 1990s, when globalization was occurring, the rapid sharing of information and movement of ideas has been something that people have really sort of linked to health. So this was a really big thing, which is that when regarding HIV, when many countries were censoring information about what it is and how you actually get it and what you can do to protect it, etc., that ability to share information in non-official ways, so whether that was like emails and faxes or to be able to travel in different ways, is was valuable and important and life-saving. So my perspective on the growth or the more democratization of communication technologies, and so you use the word technologies, and I'm thinking that you're probably talking about social media and other kinds of communication as being really important. So I've always had a positive view about that, which is that breaking down barriers of access to barriers to accessing information and sharing information tends to be a good thing regarding health and well-being. So, it can be as silly as, if you do 3 stretches of these kinds in the morning, you'll be better. I mean, that might be silly. But more fundamentally, if people are able to share information very quickly and rapidly across countries which have different kinds of political regimes, then that actually has motivated different kinds of policies and responses that I think is really important. So I think that there is definitely a very good side of this, and I haven't really studied the exact dynamics over the last 2 years about who did the positive stuff and who did the negative stuff, kind of thing. But I think that so I tend to see a very positive role about more information, more free access, more free dissemination, etc. The misinformation, I think, is for me also been always present. The idea of people trying to confuse the issue or to misdirect the issue, to provide misinformation on purpose for for malicious intent, I think has always been the case. So whether it be and health is one of these things that people take very seriously in their lives, and so are more likely to be sort of willing to listen to sort of things that they find troubling. And people know that, and that's why they talk about health a lot, because they know that they'll get people's attention as well. So in terms of, I don't know if you were talking about what it stands in my sort of view. I think, as I was saying, is that there is a really fundamental role in free and accurate press in being able to address social crises. The second thing is the point of the free and accurate press is that if policymakers and politicians don't do something about it, they should lose their jobs as a result. So if people don't lose their jobs, then the free press isn't going to really matter very much. And so what's happening here and what I'm seeing is that actually the governments have purposefully engaged in sort of manipulation of information. So we know that that sort of happens all the time in terms of political framing and lobbying and all this kind of stuff. But the actual sort of some governments actually intervening into the other governments in order to be able to manipulate the information to harm the societies, I think is a real threat. And I think that that is something that we need to consider. What I think is under considered is this idea that health is something so valuable that if you provide misinformation about it, then that's a kind of special kind of crime, right? So imagine if you were doing some sort of fraudulent which asks you for your money and they sort of send you lots of information that's misleading and you fall for it. That's actually a crime. But if they send you misinformation about drinking bleach so that you can cure yourself of COVID, you don't really get charged as that being as significant as issue. It's something that you did on your own and it's your own volition. So I think that there's something quite important there, that the information, misinformation, the crimes against health and public health are not recognized as being sort of distinctly sort of important. Sorry, I could talk about this for hours, so I'll shut up in case people have questions. But I think that this is an area for all of you. I think this is really important. What I really wanted to get to talk to you about is that there is lots of links between health and information and sound knowledge, and so we need to think a lot more about that.
Thank you, Sridhar. We have a few questions from our audience. So the first question that I'm going to take here is, what do you think can be the driving force in having the United States look at healthcare with a different lens? We know what the issues are, but it seems we just are not implementing the right policies.
Yeah, so I think my instinct today, it might have been different 5 months ago, and it'll probably be different, sort of a few months from now. Sort of two things is that I think that the health discussion in the United States has been hijacked by people who work in healthcare. And so it's such a large business, and I don't know if you know the numbers. So annually, US spends $3 trillion on healthcare, which is the highest amount that any country in the world spends on healthcare. And the thing about it is that clearly the US does not have the best health outcomes in the world, and millions of people actually don't have healthcare, access to healthcare, so they're not even spending any money on healthcare. So this enormous problem is not that we know what the right policies are, it's that there is this healthcare industrial complex here, and no one is sort of, because if you are anyway sort of try to sort of focus on healthcare as being something that we're spending too much money on, you sound like someone who doesn't want to protect people from disease and disability, and you're sort of sounds like you just want to save money, right? But there is a real problem here. It's just the same kind of problem in which over the last 2 years the pharmaceutical companies ended up with billions of dollars in their pockets, and even though the public subsidized them, and the question is, we're not going to ask for that money back, it's the same kind of dynamic. So I think that we need to do a lot more thinking about who is actually in charge of the health debate in the US, why is it happening the way it is, but also what we need is leadership in regard to thinking much more about health. And surprisingly, if you actually look at the health leadership across states and also even across the federal government, I would challenge you to find that one or two leader who says we need to focus on health, not just access to health care. And that's, I think, the really important thing is that as politics are a gruesome process, but the way to get to the top is not necessarily going against the healthcare sort of issues, but also to see yourself as sort of, not sort of focusing on healthcare but health and being very problematic about it. But so it's I challenge you. I mean, sort of find people that you think are really good leaders at the state or national level that are trying to get us to think about the causes of health rather than just access to healthcare. And I think you'll find very few because they're so caught up in the whole sort of healthcare debate and business. So I would say that would be my two sort of responses to what you're saying. So just sort of on the third bit, I think that the pandemic has really brought home to people that the reason why people get sick is because of long-term systematic disadvantage, not because of what they do as an individual. And I think I'm hoping that that will be one of the turning points in the American health and healthcare debate is that people suddenly realize that, oh, these people are not sick and dying prematurely because of what they do as individuals, but because of this systematic disadvantage. And we need to start addressing that as a matter of health and as a matter of health equity. Thanks.
Thank you, Sridhar. We do have one more question. Your talk was excellent and well reasoned, very much at the mindset level. Can you identify one or two specific things, in quotes, that would embody the kind of mindset you are suggesting? Those things could be programs, products, information campaigns, individual behaviors, and the same individual also commented on the public health misinformation idea as a crime is a great example. That's the question.
So I guess when you mean mindset, I think you mean a way of thinking or sort of, okay. So this is a great compliment because, I don't know if you know, but I'm a philosopher. And so my whole job is to get us to think about ideas and think about ideas differently and concepts differently. So if you think that this is about a way of thinking differently, I've done my job. So in terms of what can we do in practically in order to be able to change to this kind of thinking, so I think that, let's say, one of the things is that despite having spent 2 and more years in this pandemic, there is very little discussion about the idea that lockdowns helped individuals prevent infections. And so it's always been about sort of mask or no mask or vaccine or no vaccine. It hasn't been very much about this idea that, the way that we protected people from a fatal infection was to enable them to sort of stay at home and sort of limit their exposure. So this idea of, focusing on what those things did for individuals and their ability to avoid a health threat, I think is one kind of focused thing that we could do in terms of talking, rather than just talking about masks and vaccines. We can talk about, helping people protect themselves for a period of time till the vaccines came. Another example that I think would be really useful is to talk about health inequalities. We don't talk about health inequalities in the United States very much, and there's a very particular story to it, which is that everywhere else in the world we call it health inequalities. In the US, we call it health disparities. And that's because different organizations did some political polling, and they found that if you talk about inequality, people automatically assume that you're of a particular political party. And then also that in order to move anything through the political process in the United States, you need support of both sides of the political spectrum, and therefore if you use the word inequality, you're going to lose a lot of political support. And so they talk about health disparities because then that says, oh, these are differences in health, and then we don't know quite whether or not these are valid or problematic differences or not, and that's something that we leave up to sort of other areas to find out. And so I think that's another thing that we can start doing, is actually using the word health inequalities to say that, you know, this is not just a difference between the health between a right-handed person and a left-handed person. Health inequalities happen between, you know, sort of social groups of different kinds, and we need to start thinking about why are two sort of, you know, social groups having very different health and stuff. So those would be two examples in which I think this particular mindset, as you called it, would actually start to move people to think about the things that I'm thinking about.
Thank you, Sridhar. And we will take our last question. So the last question is, how do we deal with issues where there is a conflict between behaviors that encourage health and behaviors that signify membership in a social group? It seemed that vaccination in the US was seen by many as an indication of political, cultural, and social affiliation, not a health measure.
Yeah. So so this is what I was talking about why it's so useful and valuable to look across countries to see how different countries dealt with this one similar kind of phenomenon but had a vastly different kind of response to it. So I was really surprised to hear from my friends and family that in some parts of the United States, if you wore a mask, that was a sort of essentially announcing your political membership to a particular party. And that, you know, people were, you know, essentially, you know, having to, you know, face sort of social, you know, identification of something very personal by wearing a mask, is that rather than sort of people thinking of them as being careful about their own health and wanting to prevent infections, that they were simply saying, well, I belong to this party, and if you don't wear a mask, that means that you don't belong to my party. I thought that this was a great tragedy and travesty of this pandemic in the United States, and it's reflected in the people that died, is that a lot of those are people that died as a result of falling into these kinds of traps of, I won't do that because that's not me, that's not the social group that I belong to. In comparison, in the United Kingdom, there is a left wing and a right wing, or a left and right, or a conservative and liberal. But the mask use was, you know, enormously high while we were in sort of in severe conditions, which we still are. But, you know, the vaccine, in, you know, sort of take-up rate is around 70% or 80% or something like that. And that is across political spectrums. And that has something to do with the way that vaccinations were not, they were done by something called the National Health Service, which is the kind of standard health service that we have. And because they were done through the National Health Service, everybody goes to the National Health Service, whatever your political leanings. And so that was sort of considered to be one way of doing it. I think the United States failed enormously in sort of not being able to sort of unlink the political you know, sort of rhetoric with the public health or health intervention response here. But I also want to say that we have to acknowledge and recognize that this politicization was done purposefully by various groups and individuals. So if you want to sort of trace the question about mask or no mask, it didn't randomly rise up in populations. This was something that was done as a kind of polarizing sort of ability to divide people, as was the vaccine. I mean, so imagine as a taxpayer, you paid your taxes and billions were put into vaccines, but then you say, no, I don't want to use the vaccine because, you know, I don't trust it. It's like, well, you actually paid for it. and you're going to be paying for it for a long time. And so, why would you reject something that you actually paid for? So, I mean, there's lots of ironies there, but I think, in terms of strategies, I think that, looking to other countries to see how they mobilized, how they delivered not only vaccines, but think about other health interventions in which it doesn't cut across political, sort of polarized, divisive lines, I think is a really important thing to focus on in the future.
Okay. So Sridhar, on behalf of the University of Maryland's iSchool community, I would like to thank you for taking the time to be with us and share your thoughts and ideas. My invitation remains to you. We would like to have you in person at the iSchool at some point. In your next visit to the US, please feel free to reach out to me or to the dean, and we would love to host you here. Thank you to the audience for great questions. And thank you again so much, Sridhar, for your very, very thoughtful talk. Thank you.
Brilliant. Thank you very much for the opportunity and lots of luck.